So welcome to Advances in Targeted Therapy, the role of VEGF and EGF receptor inhibitors in metastatic colorectal cancer. My name is Axel Grothe. I'm welcoming you to this educational activity, which is online, and we will cover a lot of ground talking about modern treatment options and sequential treatment options for the management of patients with metastatic colorectal cancer. Here's my disclaimer, and we will talk about some drugs with unlabeled use. Here's my disclosure of conflict of interest and the activity agenda. We'll talk about the role of VEGF and EGF receptor pathways in metastatic colorectal cancer, targeted therapy options in the management in terms of the continuum of care for metastatic colorectal cancer, incorporating targeted therapy into first-line treatment and beyond, and we'll actually have some case studies to apply what we've talked about in a practical manner. So learning objectives on completion here, you should be able to describe the rationale and role of VEGF and EGF receptor targeted agents in the treatment of metastatic colorectal cancer, use molecular testing to guide your treatment selection, assess safety, efficacy, and when appropriate, incorporate current targeted therapies into the treatment armamentarium of metastatic colorectal cancer, and assess emerging targeted therapy options in this disease, including emerging data on immunotherapy. So let's dive into the role of VEGF and EGF receptor pathways in metastatic colorectal cancer. And this ties into the idea that with the availability of targeted therapies, we have broadened our armamentarium to treat metastatic colorectal cancer. And we know that exposing patients sequentially to all active treatment options really is what keeps patients alive. The more treatment options we have, the longer patients will live. And over the last years, over the last decades, actually, we have really added a lot of targeted agents to the treatment portfolio of patients with metastatic colorectal cancer. In 2008, I think, importantly, we realized that we need to test for a biomarker. That's the first biomarker we really introduced into the management of colorectal cancer, KRAS mutation, because we know that cetuximab, panitumab, the EGF receptor antibodies don't work in patients with KRAS mutation. Now we know it actually extends to all RAS mutations. We'll talk about this in a moment. Now I think the distinction between EGF receptor and VEGF pathway inhibition is very important. It's very critical to keep in mind that when we're targeting EGF receptor, we're targeting an antigen on the surface of tumor cells. It's a direct tumor cell hit. And since we know that tumor cells are genetically unstable, they are heterogeneous in terms of pathways, and there might be mutations in downstream signaling pathways, we've recognized that these mutations can actually serve as predictive biomarkers for the activity of the tumor cell targeting EGF receptor antibodies like cetuximab and panitumab. This is exactly what highlights the importance of RAS mutation and potentially BRAF mutations to select treatment options for our patients. Now, VEGF inhibition is different. We're targeting endothelial cells, genetically stable cells, not genetically unstable tumor cells. So the effect of the endothelial cell targeting agents, VEGF inhibitors, VEGF receptor inhibitors like ramucirumab, is not mediated by, let's say, or affected by a mutation somewhere downstream in signaling. In fact, we have not yet identified a single predictive biomarkers for the use of bevacizumab, aflibercept, ramucirumab, or the VEGF inhibitors. And it might very well be that we'll never find a biomarker that can really distinguish between yes or no activity of these agents like what we have with EGF receptor antibodies. Now, when we look at the role of angiogenic pathways in colorectal cancer, we know that angiogenesis is important for this disease, and we have ample evidence that anti-angiogenesis agents work in first line and second line and in first to second line therapy, because new blood vessel formation is very important for progression of metastatic colorectal cancer. We know that the VEGF system is one of the critical regulators of this process, and we can, by inhibiting angiogenesis, we can kind of control the disease better with various mechanisms. We have known that VEGF is important in the early progression of colorectal cancer, highly expressed in tumors, correlated with poor prognosis. There's a lot of rationale why we use anti-VEGF therapy in these patients. Now, when we talk about biomarker, again, the other biologic agents KRAS and NRAS testing, and this kind of preempts what I'm going to talk about later. When we introduced KRAS testing in 2008, we looked at 40% of patients with mutations in exon 2, mainly codon 12 and 13, that had mutations. And now we have expanded this analysis to cover all RAS, meaning KRAS exon 2, 3, and 4, and NRAS exon 2, 3, 4. And overall, we're probably looking at about 50 to 55% of patients now that have RAS mutations. And when we find these RAS mutations, panitumumab and cetuximab simply don't work and should not be used. There might even be some detrimental effect, in particular when we combine cetuximab or panitumumab with FOLFOX or with oxaliplatin-based therapies. So turning our attention to the idea of the treatment continuum for metastatic colorectal cancer, sequential therapies with the idea of keeping patients alive as long as possible, and how targeted therapies fit into here. We'll focus first on the large molecule VEGF inhibitors. We know bevacizumab is an antibody against the ligand VEGF-A, the ligand for the VEGF receptor 2, which mediates mainly the pro-angiogenic pathways through the VEGF axis. Ramucirumab is an antibody against VEGF receptor 2, recently shown with efficacy in colorectal cancer. Aflibercept is a fusion protein which binds VEGF-A, what bevacizumab does, but also placenta growth factor and VEGF-B. Most of the activity is likely mediated through the inhibition of VEGF-A, though. The study that brought us bevacizumab into our portfolio is the so-called Herbert study. At the time when we used IFL as one of the chemotherapy backbones, bevacizumab was added in a placebo-controlled phase 3 trial, and it was clear to see that the addition of bevacizumab improved progression-free survival and overall survival. There was no crossover allowed in the study. Response rate was somewhat increased, but not as dramatic as the time-related endpoints. And I think we have recognized that the strength of bevacizumab is really delaying tumor progression. And this is evidenced in the progression-free survival curve on the next slide, with a hazard ratio of 0.54, a very strong biologic effect of 46% reduction of progression events, strong p-value, and the median, of course, is statistically significant. So when you look at the shape of the curve, it also is apparent that these curves separate early, and they stay separated for most of the study cohort until patients eventually progress. And the early split of these curves is something I'd like to point out, because we'll come back to that point at a later time point when we talk about EGF receptor antibodies. Now, IFL is an obsolete regimen. Most of us use FOLFIRI or FOLFOX. Bevacizumab was added to FOLFOX or capecitabine oxaliplatin in the so-called 966 study, a large study conducted internationally. Eventually, 1,400 patients with a 2x2 randomization, CAPOX or FOLFOX, placebo, and bevacizumab. And interestingly, at the time when the study was conducted, the primary endpoint of the study was not that strongly effective. It was statistically significant improvement of progression-free survival, but not as strong as before in the IFL study. And a lot of it has to do with the fact that patients stopped treatment early because of neurotoxicity, and the investigators really didn't keep patients on the study until progression. But a pre-planned subgroup analysis, and this is a very important point about the so-called on-treatment population, the treatment population that actually continued treatment to progression, showed that the addition of bevacizumab to FOLFOX in capecitabine oxaliplatin was actually strongly quite effective, with a strong hazard ratio of 0.61 and 0.65, which are statistically significant. This actually points to the idea that we should not stop treatment too early. We really need to treat to progression, at least to progression. We have now data even to use VEGF inhibition beyond progression. We'll come back to that later. So the overall survival analysis eventually showed not a statistically significant improvement, but the study was powered for progression-free survival, not for overall survival. I think we've all acknowledged that bevacizumab does contribute efficacy in terms of delaying tumor progression and moving eventually overall survival out in an incremental manner. Now, bevacizumab has recently been added to more, let's say, aggressive treatment options like FOLFOXIRI. The so-called TRIBE study was published in New England Journal of Medicine in 2014. compared FOLFIRI versus FOLFOXIRI. Both arms added bevacizumab. And the investigators looked at an induction maintenance therapy approach, so 12 cycles maximum for this triplet combination, and then patients were kind of maintained on a fluoropyrimidine plus bevacizumab combination. When we look at the data, the primary endpoint was achieved with a long progression-free survival here of 12 months and an improvement in response rate, which was statistically significant. In the initial analysis of overall survival, there was a trend toward improvement. The most recent analysis actually did show a significant improvement in overall survival. What I want to point out here, though, is the duration of median overall survival, which is around 30 or 31 months for the FOLFOXIRI bevacizumab arm. And I think this is quite remarkable. The way I use this information of this study is that bevacizumab is combinable with a triplet combination chemotherapy. So this is part of our options that we have to treat patients and could be interesting for patients who have large tumor load, need tumor shrinkage, rapid tumor shrinkage, might have a RAS mutation so that EGF antibodies cannot be used. Now the combinability of VEGF inhibitors, now we've talked about doublet chemotherapy, we've talked about triplet chemotherapy, but the combinability is also true for a single agent fluoropyrimidine. The AVEX study here, which looked at patients over the age of 70, median age here was 76, trial conducted mainly in the United Kingdom, randomizing patients to capecitabine as first-line therapy or capecitabine plus bevacizumab. And I like the study very much because it shows the clinical synergism between capecitabine plus bevacizumab, as shown in the primary endpoint here, progression-free survival, which was reached and quite strong with a hazard ratio of 0.53, very strong significant p-value. When we look at the 9.1 month with median progression-free survival, that's actually very strong for just a single agent fluoropyrimidine plus bevacizumab. The data are as impressive in my eyes as the data of IFL plus minus bevacizumab. Overall survival was the secondary endpoint. There's a trend toward improvement in overall survival, but overall survival in general in this elderly patient population of 21 months is quite remarkable and highlights again that the combination of a fluoropyrimidine plus bevacizumab is clinically very active. Now, this combination of fluoropyrimidine plus bevacizumab can be used also to form a very active maintenance therapy approach. This was shown in the CAIRO3 trial, one of several maintenance therapy trials which have recently been presented and published. The idea of CAIRO3 was to use an induction chemotherapy regimen of capecitabine oxaliplatin plus bevacizumab. It's a 3-weekly regimen for 6 cycles, meaning 18 weeks. And if patients had at least stable disease, they were randomized to continued capecitabine plus bevacizumab or a treatment-free interval. And upon progression, when progression-free survival 1 was reached, patients were supposed to be re-exposed to capecitabine oxaliplatin bevacizumab. But some patients, and the primary endpoint of the study was actually progression-free survival 2, meaning upon progression on this reintroduction therapy. But some patients actually did not receive capecitabine oxaliplatin bevacizumab as reintroduction. They used a different therapy, for instance, irinotecan-based. So another endpoint was created, the time to second tumor progression. And however we slice and dice it, the study was positive for its primary endpoint, and very strongly suggesting that the use of this maintenance therapy really delayed tumor progression with a very strong hazard ratio for PFS1 and PFS2. What I also like in this study is that capecitabine here was used in a different way than we normally use it, not a 2-week on, 1-week off regimen, but a continuous treatment of 625 milligrams per meter squared twice daily without a break, and bevacizumab was added at 7.5 milligrams per kilogram every 3 weeks. That's pretty convenient for patients, and in my hands, actually something that I use as one of my standards of care. Now, the effectiveness of delaying tumor progression is shown in this curve here on progression-free survival 1, hazard ratio very strong with 0.43, meaning a 57% reduction of progression events on the study. Overall survival trended toward improvement in the statistically significant improvement. If we just look at the median of about 3.5 months, it shows that the from start of randomization or from start of the actual therapy shows that if we do not perform maintenance therapy, we can never make up for the difference in the end. So even though the difference here is not statistically significant, I think it's clinically meaningful and has shaped a lot of our approaches using the induction maintenance therapy approach in first-line therapy, in particular in patients who receive oxaliplatin-based regimen as first line. Now, we've talked about that duration of anti-VEGF therapy matters. We should treat to progression, preferentially employ induction maintenance therapy strategies. I think this idea of prolonged duration of VEGF inhibition being active is also highlighted in the data from the treatment approaches where in clinical trials, bevacizumab and other VEGF inhibitors were used beyond progression, like the so-called TML study, which was a European study, 820 patients. Any chemotherapy backbone was allowed, and upon first-line progression, patients switched chemotherapy and then either continued or did not continue bevacizumab until progression and beyond progression here. The study was positive for its primary endpoint, overall survival, with admittedly a moderate effect, I would say, with a hazard ratio of 0.81 for survival, meaning a 19% reduction of death events. But since the toxicity was very mild, I think this difference was clinically meaningful. Adverse events really like what we expect from bevacizumab as a VEGF inhibitors. Very small numbers of patients that had GI perforations, wound healing complications, or any significant bleeding. So I think we have really learned how to manage and preempt these side effects of bevacizumab over the years. Now, this concept of bevacizumab beyond progression or VEGF inhibition beyond progression has been picked up by other agents. Now, aflibercept was tested in a very similar environment in a second-line setting, added to FOLFIRI versus placebo. Not all these patients had prior bevacizumab. Only 30% of patients received prior bevacizumab in first-line therapy. But the study was positive for its primary endpoint, overall survival, with a similar magnitude as the bevacizumab beyond progression study, about an 18% reduction of death events and a significant improvement in progression-free survival. The problem with the aflibercept study was, however, that there was an increased risk of more chemotherapy-like, chemotherapy-related toxicities, like complicated neutropenia, asthenia, stomatitis, infections, something which we don't expect from a pure VEGF inhibitor. And what is concerning, or was concerning actually, that a lot more patients discontinued the aflibercept component versus placebo in the VELUR study. So there's something which has kind of probably affected the use of aflibercept in our clinical standards. Most of physicians at this point in time will probably prefer bevacizumab, which has a better safety profile. Now, ramucirumab is another agent that inhibits the VEGF system. It's an antibody against VEGF receptor 2. We had initial data from a phase 2 trial with modified FOLFOX6 plus ramucirumab, which indicated that the drug was potentially quite active. And ramucirumab's adverse events profile is very similar to what we see with bevacizumab. It's really a pure VEGF inhibitor. So we see hypertension, a little bit more diarrhea potentially when you add it to chemotherapy and keep patients on therapy longer. Very little infusion-related reactions as a pure human antibody. And so this toxicity profile, which we've also established in gastric cancer, for instance, is pretty mild. Ramucirumab was tested in metastatic colorectal cancer in a second-line setting in patients who had all received prior bevacizumab and oxaliplatin and fluoropyrimidine. More than 1,000 patients were randomized in second-line treatment to FOLFIRI plus ramucirumab or placebo, and the study was powered for overall survival, and overall survival was reached. Overall survival endpoint was reached and met with a statistically significant difference, median improvement of 1.6 months and a hazard ratio of 0.84, very comparable to what we've seen with the other VEGF inhibitors, aflibercept and bevacizumab. When you look at the overall survival forest plot here, There was not a real one subgroup that did not benefit. All trended toward improvement or was statistically significantly improved with the use of ramucirumab added to FOLFIRI. Same is true for progression-free survival. Again, clear evidence that another agent shown that VEGF inhibition beyond progression is associated with improved overall survival in colorectal cancer. Response rate, and this is interesting, in patients who have previously been treated with bevacizumab-based therapy, continuation of VEGF inhibition beyond progression does not seem to improve responses, complete or partial responses. We see improvement or trend to improvement in disease control rate. This is really the delaying of tumor progression that's the highlight of these VEGF inhibitors. As mentioned before, ramucirumab has a side effect profile very similar to bevacizumab with bleeding, hypertension, proteinuria, and some thromboembolic events being higher, and a very low number of GI perforations. But again, these data are very similar to what we've been used to see in bevacizumab. Now, when we compare all these phase 3 trials, and the first table here shows aflibercept with the whole cohort, with the previously pretreated and not pretreated bevacizumab patients, we see that the hazard ratios as best read of efficacy here in this endpoint for overall survival are about the same. Hazard ratio 0.81, 0.82, and 0.84 for bevacizumab, aflibercept, and ramucirumab. So we see a moderate effect in terms of overall survival improvement, but consistent across these three different agents. The second table here, which is slightly different, looks at the bevacizumab pretreated patient population, the aflibercept VELUR study. You can see that the efficacy in terms of hazard ratio is slightly attenuated with a hazard ratio now of 0.86 and no increased response rate anymore. So I think overall, I don't believe that there is one VEGF inhibitor that stands out in terms of this is the preferred agent that we should use in second-line therapy. So when we conclude anti-VEGF therapy, I think it's very clear, and this is very important, that duration of anti-VEGF therapy matters. We should treat the progression, implement maintenance strategies, and we have clear data, 3 phase 3 trials, that treatment beyond progression is helpful and improves survival. We see clinical synergism between fluoropyrimidine plus bevacizumab. Again, this can be used to optimize maintenance strategies. I don't think, that aflibercept or ramucirumab or bevacizumab really have kind of that one of these agents is better. I don't think this will ever have head-to-head comparisons. I think we're going to vote with our feet and probably also look at financial implications because there is a big difference in cost between ramucirumab, for instance, and bevacizumab. We've seen that bevacizumab is combinable not just with fluoropyrimidines but also with a triplet combination. And we've seen recently the approval of ramucirumab as component of second-line therapy. Now, at some point, patients will have tumor progression in spite of the best anti-angiogenesis therapy. And what we've learned over time in our concept is that the idea that tumors still need blood vessels still holds up in order to, if they want to grow. So what happens here and what can we do to overcome these resistance mechanisms? Very elegant study from MD Anderson Scott Coppett's data showed that on patients who received FOLFIRI plus bevacizumab, there was an upregulation of pro-angiogenic cytokines while these patients were on therapy. And the interesting point was it's not just one factor like basic FGF or placenta growth factor, etc., but it's a pattern of factors, and it could actually be different from patient to patient. So there's not just one target that we need to, one cytokine that we need to target to overcome resistance. And this is one of the rationales why we looked at regorafenib, a multi-kinase inhibitor that targets various kinases and which are involved in pro-angiogenic factor pathways, but also proliferative pathways in tumors. We looked at regorafenib as a very promiscuous agent that can potentially counteract all these various pathways that could be upregulated in a later line setting when patients have progressed on, let's say, 1 or 2 or 3 lines of therapy. So the regorafenib inhibits various kinases targeting multiple tumor pathways, angiogenesis pathways, and proliferation pathways. Regorafenib was tested initially in a randomized phase 3 trial that brought the drug eventually to FDA approval, a 2-to-1 randomization of regorafenib against placebo, and patients that really progressed on all standard therapies, including all available chemotherapy options, bevacizumab, and if KRAS exon 2 wild-type, cetuximab or panitumumab. 760 patients were randomized within a very short time frame, indicating the unmet need. The primary endpoint of the study was met with an improvement in overall survival with a hazard ratio of 0.77, meaning a 23% reduction of death events. Median difference 1.4 months, which was very similar to what we've seen with the VEGF inhibitors in second-line therapy. Progression-free survival curve indicates that the split of this curve is about at 50%, meaning there's no difference in the median. But the way I explain it to my patients is when we see the first scan at 8 weeks, they have about a 50-50 chance to have no progression on regorafenib compared to placebo. And the hazard ratio of 0.49 is really carried by the tail of the curve here, 51% reduction of progression events. Now, regorafenib is not necessarily an easy drug to use in terms of side effect management. Side effects come early, and they come potentially with the worst degree right on the very onset of these side effects. And what we see mainly and what patients complain about is hand, foot, skin reaction, sometimes affecting feet more than hands with blisters on their feet. And I personally tell patients that they should remove calluses and actually get a pedicure before they get on regorafenib. They should use keratolytic urea-based lotions and creams on their hands and their feet. This kind of mitigates the hand-foot skin reaction. Fatigue is another issue, of lesser issue, diarrhea and hypertension. Now, we've also seen that the pattern of side effects is different in terms of its time course. As I mentioned before, the worst side effect can occur actually at the very beginning within the first 2 or 3 weeks. That's why we need to monitor patients quite closely on this drug and see them or talk to them on a weekly basis initially. But over time, the side effects actually decrease in severity, and it's almost like as if patients get used to the treatment and can tolerate regorafenib better over time. Now, the correct study was only the one of actually 2 phase 3 trials. The other study, the so-called Concur study, was just recently published in Lancet Oncology. It was a trial conducted in Asia, a smaller trial, using the same randomization, 2-to-1 regorafenib against placebo. And this study actually had the important point that not all patients had to be pre-treated with all active agents. So there was about a 40% of patient group that did not have prior bevacizumab or anti-EGF receptor therapy. So it was a less heavily pre-treated patient population, and the overall survival effect for regorafenib was stronger here, hazard ratio of 0.55, a 45% reduction of death events, and a larger split in the median. So whether this is really related to the less heavily pre-treated patient population is not easy to say, but it's very intriguing to see that the curves actually split wider. Now, this is the idea that the numbers of lines of therapy and prior targeted therapy might have affected outcome is further supported by a pre-planned subgroup analysis looking at patients with prior targeted therapy and without prior targeted therapy. You can see that the split of the curves is much larger, much wider for the patients who had not received prior targeted therapy. Although now we're talking about a subgroup analysis of a relatively small phase 3 trial and a small patient population here that is looked at. When we compare these 2 different trials, what stands out really is the number of patients that had access to prior biologic therapies, and whether this really drives the stronger difference in survival and progression-free survival that we see in the Concur study is somewhat speculative, but it's probably the best explanation that we have at this point in time. Now, regorafenib is not the only single-agent drug that has shown to be effective as salvage therapy. There's another agent which I hope will get approved very soon. This is a chemotherapy drug. It's a fluoropyrimidine, actually fluorothiamidine, TAS-102, which was actually synthesized in 1964, was considered not effective, not stable enough to be used in humans was only kind of made stable enough, and when the metabolic enzymatic step was inhibited by tipiracil, so what's considered here TPI, inhibits the metabolism of this trifluridine, and TFT will eventually get incorporated into DNA, disrupts DNA replication. So it's a clear cytotoxic agent, similar but not identical in its mechanism to 5-FU. So TAS-102 was tested in a phase 3 study, a global phase 3 study, very similar design compared to the regorafenib studies, 2-to-1 randomization against placebo. Drugs being given orally twice a day, day 1 to 5, and the 8 to 12 on an every 4-week basis, meaning, so for instance, Monday to Friday, and then 2 weeks off. Primary endpoint was overall survival, and overall survival was reached here with a statistically significant difference in a hazard ratio of 0.68, a 32% reduction of death events. And these patients were all heavily pretreated. Progression-free survival, very similar and actually identical to the curve we've seen with regorafenib, with a hazard ratio of 0.48, and a median that doesn't really show a difference, because at the time point when patients get to their scans, about 50% of patients, even on TAS-102, have progression of their disease. Now, the main side effect of TAS-102 is neutropenia, leukopenia. About 40% of patients have grade 3-4 neutropenia. A lot of patients actually have to delay their second cycle or third cycle of therapy, but we have very minimal non-hematologic toxicity. This drug does not induce hand-foot syndrome, very little fatigue, very little diarrhea, very subjectively very easy to tolerate for patients. So now we have regorafenib and TAS-102. We have several phase 3 trials here. It will be interesting to see how we as physicians, oncologists, will sequence TAS-102 and regorafenib. We know that regorafenib does not work in patients who have too deteriorated performance status, and we have no data on regorafenib after TAS-102. We have some data on TAS-102 after regorafenib, because in the RECOURSE study, the phase 3 study on TAS-102, 17% of patients actually had regorafenib, and they had the same benefit as patients who had not had regorafenib before. Now let's turn our attention to the EGF receptor antibody therapy, which, as I mentioned before, targets tumor cells directly on the surface of their membrane by binding to the EGF receptor, inhibiting ligand-based activation, and thereby potentially shutting down the downstream signaling pathways. We know that if RAS or other factors are activated, meaning mutated, for instance, like RAS mutations, whatever happens upstream doesn't matter anymore, and so it's not effective anymore. So we have a negative predictive marker in RAS mutations for the usefulness of EGF receptor antibodies. Now, what really happened over the last 2 or 3 years was the recognition that we need to go beyond just KRAS exon 2 testing for very important reasons. Number one, we have known that if we combine, for instance, FOLFOX with panitumumab in mutant KRAS tumors, and this is data from exon 2 mutations, we see actually a detrimental effect in terms of progression-free survival, whereas we know that when we add panitumumab to FOLFOX in wild-type KRAS tumors, we actually see a beneficial effect for progression-free survival. Now, the panitumumab studies did a very important service to our community by looking at further RAS mutations, as shown here on this slide, exon 3, exon 4 of KRAS, and NRAS exon 2, 3, 4. So another 17% additional mutations in KRAS and NRAS beyond KRAS exon 2 mutations were found. And when we looked at these data, it was very clear that when we look at the all RAS wild-type tumors, now we actually see a benefit, a stronger benefit for the use of panitumumab added to FOLFOX in the first-line setting, with including an overall survival benefit, which was now statistically significant. Unfortunately, the FDA still hasn't embraced this all RAS testing. They still have just the label that we see that FDA approved, look at KRAS exon 2 mutation. the label changes are coming into place right now, and guidelines have been changed so that now NCCN guidelines, for instance, mandate comprehensive RAS testing, not just KRAS exon 2, before EGF receptor antibodies are being used. And the reason for that is on this slide here, the forest plot. We know that patients who have non-mutated KRAS exon 2 but mutated other RAS, the last line of the slide here shows they might have a detrimental effect, clearly no benefit, and patients who have any RAS mutations should be excluded from the use of EGF receptor antibodies. Now, one of the other topics in the recent years, a year and a half or 2 years, was the head-to-head comparisons between bevacizumab and cetuximab. There are actually 2 trials which, on a phase 3 level, which were presented and published. The FIRE3 trial was the first trial, a German-Austrian trial, looking at FOLFIRI plus cetuximab versus FOLFIRI plus bevacizumab at frontline therapy in KRAS, initially KRAS wild-type tumors. 600 patients randomized here, and very unusual primary endpoint for a phase 3 trial, overall response rate, investigator assessed. Interestingly, there was no difference in the ITT population in the response rate, something that surprised me because I thought cetuximab as a tumor-directed agent would have actually induced higher response rate added to FOLFIRI. As expected, no difference in progression-free survival, but the surprise came that with a late split in the overall survival curves, the overall survival was different, and there was a statistically significant difference in favor of cetuximab added to FOLFIRI. So no difference in response rate, primary endpoint, no difference in PFS, but difference in overall survival. And this was kind of a little bit unexplained because the progression-free survival time is really the time that is controlled by the study, but the split of the curve comes at about 2 years. So the question was, did post-first-line progression imbalances might have contributed to the split of these curves at a later time point? It's also important that the actual split, when the curve split, the difference is carried by very few patients. So there's a lot of uncertainties whether these data were actually really reflecting reality. So what could have happened? Could there be imbalance in post-progression therapy? Could it be that there is a best sequence of things, that EGF receptor antibodies work better in first line or VEGF inhibitors better in second line after prior EGF receptor therapy? Questions were out there. And could there be a subpopulation that's very sensitive to EGF receptor antibody therapy? And that is really what's driving the difference. Now, the FIRE3 investigators also tested for additional mutations. I think that they turned this around within a very short time. Similar to the panitumumab trial, they found about 15% additional RAS mutations, eliminated those patients from the analysis, and then saw a larger split. The median difference now was 7.5 months, hazard ratio stronger, 0.7. But again, as a secondary endpoint, which surprised the oncologic community, we're still kind of trying to wrap our head around it, what's happening here. So it would have been nice to have a larger study that had an appropriate endpoint in overall survival that could confirm or refute the data of FIRE3. And fortunately, we have the study at hand. It's the intergroup study, CLGB SWOG 8405, head-to-head comparison between bevacizumab and cetuximab added to dealer's choice chemotherapy of FOLFOX or FOLFIRI. Study had a long history, was amended a couple of times, and eventually came to this design of 1,142 patients with KRAS exon 2 wild-type tumors, FOLFOX or FOLFIRI plus bevacizumab or cetuximab. In the US, 70% of patients here received FOLFOX, a US-based study, and primary endpoint, importantly, was overall survival. And we can go through the next slides very fast because there's absolutely no difference in progression-free survival and overall survival between chemotherapy plus bevacizumab or chemotherapy plus cetuximab, progression-free survival, overall survival on this slide here. Then we look at the FOLFOX or FOLFIRI-treated patient population. Again, no statistically significant difference. There might be trends in one way or the other, but including the FIRE3 population with FOLFIRI-based therapy, clearly no difference that would really be on par with what we've seen in FIRE3. I want to point out that the duration of patients' overall survival is quite long, and we're looking at 30 to plus months, which is very encouraging for patients. Now, the 8405 study also looked at extended RAS analysis, very similar to what we've seen before. And even when we eliminate all the other RAS mutation patients, the overall survival and progression-free survival outcomes are exactly identical to what we've seen before. No difference between bevacizumab and cetuximab. And we can break it down again by FOLFOX and FOLFIRI. Progression-free survival, as expected, no difference. And for overall survival, again, no difference, even in the RAS-refined patient population. I think this is very important. Now, I actually believe that these studies are very similar because there's a lot of talk about why are FIRE3 and 8045 so different. I think the studies are actually almost identical when we do a PowerPoint experiment and superimpose the survival curves on top of each other. We can actually see that the curves are really very close to each other, and that the only outlier is really the FOLFIRI plus bevacizumab arm in the FIRE3 study. So that is something which we need to work on and try to explain, because it could very well be that the use, how bevacizumab is being used in Germany and Austria, could compared to the United States, where we see a lot of longer duration of therapy potentially, could be the reason why this one arm didn't perform on par. Now, what Alan Vanook showed when he presented the 8405 data in plenary session was actually this very intriguing slide here, 20 years of advances in colorectal cancer, keeping in mind that we didn't have one breakthrough event in colorectal cancer, at least not yet, but that the benefit we've seen in improvement in overall survival is really the accumulation of incremental gains. 20 years later, after we established the usefulness of leucovorin added to 5-FU in a meta-analysis, now we see in 8405 a dramatic improvement compared to the historic controls here. We're moving overall survival in median from 12 months now to 30 months plus, which I think is really important for our patient population. Now, one side note that I like to point out, because we talked about the usefulness or where would EGF receptor antibodies and bevacizumab be used, and this is kind of a side note of the whole train of thought right now in terms of sequencing agents. We have established, I think, reliably that the use of EGF receptor antibodies is associated with a higher response rate, when we refine the patient population with RAS wild-type tumors. Should we use it now in a conversion therapy setting or a neoadjuvant setting in liver metastasis? And I think the data that we've seen so far are quite controversial. The new EPOCH study was presented recently and published in Lancet Oncology, which actually surprisingly showed a detrimental effect in terms of progression-free survival when an EGF receptor antibody was used preoperatively and postoperatively, so pre and postoperatively after a liver resection. I think these data stand on their own right now. They need to be looked at and potentially be validated or refuted by subsequent studies. So when we talk about the overall optimized treatment strategy, I think at this point in time, molecular testing really drives what can be available for patients in terms of first-line and second-line and third-line treatment options. If we have any RAS mutation on the left side of this slide, EGF receptor antibodies do not play a role. We have data on chemotherapy plus bevacizumab, VEGF inhibition beyond progression, regorafenib, and potentially at some point we'll have TAS1 or 2 somewhere here. If we have all RAS wild type, we have the option to choose either using, in terms of targeted therapy, bevacizumab or an EGF receptor inhibitor. And I would believe if we use bevacizumab in first line, it makes sense to continue with VEGF inhibition beyond progression, reserve EGF receptor antibodies for a salvage therapy setting where we know that they are very active, even a single agent, but it's clearly no problem and no mistake to use EGF receptor antibodies as first line, bevacizumab as second line, and regorafenib as third line. For BRAF mutant tumors, we didn't talk about this, there is emerging data that a triplet combination chemotherapy plus bevacizumab might be the best way to treat these patient population, BRAF mutant tumors, which have very poor prognosis and constitute about 5 to 10% of patients. These patients need better therapies. That's an unmet need. And I think we have a lot of data in terms of combination treatments with targeted agents that are currently being investigated. There's a lot of drug development going on right now in metastatic colorectal cancer, some MET inhibitors, BRAF inhibitors, angiogenesis inhibitors, single agent and in combination. and some of them actually talked about like TAS-102, which is still listed on this table here as novel chemotherapy. Now, I'd like to close the part of our educational session by talking about some interesting data that just came out at ASCO 2015, immunotherapy in colorectal cancer. Every tumor entity likes to be a target for immunotherapy, likes to have some patient population that benefit from immunotherapy. And we know that various immune modulators, next generation immune modulators on the market, CTLA-4 antibodies, PD-1, PD-L1 antibodies, some approved, some in clinical trials right now, and we're all pretty excited because these agents, which are quite expensive, can actually generate long-lasting, durable responses in patients. Now, the interesting thing is that in those tumors where these PD-1, PD-L1 antibodies actually seem to work, those tumors are characterized by high frequency of mutations, somatic mutations, some induced by, let's say, sun exposure in melanomas or by smoking in non-small cell lung cancers. Those are the tumors which we know checkpoint inhibitors, immune checkpoint inhibitors work. Now, colorectal cancer has a subgroup of patients which has a hypermutated phenotype, which are mainly the MSI high tumor patients, where characterized by defective mismatch repair enzymes, either by silencing due to methylation of the promoter region or in the Lynch syndrome as mutation in the actual mismatch repair protein genes. So we have hypermutated tumors in colorectal cancer, and we've known for a long time that these MSI high tumors are characterized by lymphocytic infiltrates, better prognosis in stage 2, but if they move to stage 4, in 4 or 5% of all patients with stage 4 disease, they might have actually worse prognosis, potentially because their malignant hypermutated clone is being selected that actually made it to stage 4, and actually escaped some of the immune surveillance that can otherwise control the tumor spread. So this patient population, MSI high tumor patients with hypermutated phenotype, could be a target for immune checkpoint inhibitors. This was very elegantly demonstrated and confirmed by a presentation at ASCO, which actually at the same time also appeared in the New England Journal of Medicine, PD-1 blockade in tumors with mismatch repair deficiency. The rationale is that we are kind of taking away the brakes that tumors put on the immune system by targeting PD-1 or PD-L1, the PD-L1 system. And here in the study, they used pembrolizumab, an antibody against PD-1, to treat patients with mismatch repair deficient colorectal cancer, proficient mismatch repair colorectal cancer, and a third cohort of deficient mismatch repair non-colorectal cancers like endometrial cancers, gastric cancers, etc. So the study had 3 different cohorts, and it was a small study, admittedly. MMR, so mismatch repair deficient colorectal cancer, only 13. Most of them were actually Lynch syndrome patients. None of these patients had a BRAF mutation. For the MMR deficient non-colorectal cancer, smattering of other tumors as outlined on this slide. And then there were these mismatch repair proficient colorectal cancers, which constitute the majority of colorectal cancers overall. In terms of biochemical response, this is tumor marker here, a clear separation between mismatch repair deficient and proficient colorectal cancers. And this is really this spaghetti plot over time, almost a black and white cutoff. Patients with mismatch repair deficient colorectal cancer seems to have a response, and the actual objective response rate in this last line setting, this was a heavily pretreated patient population, 62% with a disease control rate of 92% for these 13 patients with mismatch repair deficiency, compared to 0% response of mismatch repair proficient colorectal cancer, and a similar response rate in the non-colorectal cancers that were mismatch repair deficient. That's quite intriguing that we now have a biomarker, at least in these malignancies with hypermutated phenotype, that can predict whether patients have a chance to respond or not. Waterfall plot, you can see that the target lesions were quite readily affected by the mismatch repair deficient, but not the proficient colorectal cancer. Progression-free survival curves separating these cohorts out, so it is very clear that mismatch repair deficient tumors had a chance to benefit, as evidenced in progression-free and overall survival. So this is quite interesting because now we have a first study that looks at tumor genetics, the numbers of mutations that can really guide immunotherapy. And even if it only represents 45% of patients with colorectal cancer and other tumors, these patients might actually be a good target for the use of immune checkpoint inhibitors, which everyone, of course, is very excited about. So this kind of gave us a foray into kind of the next generation of trials, next generation of treatment approaches. So how do we practically apply all this now in our clinical practice? Let's look at a case study. A 67-year-old woman, good performance status, diabetes mellitus controlled, hypertension medication, has a non-obstructing rectal mass of 10 centimeters with 5 intrahepatic metastases as well as retroperitoneal nodes, increased CEA, and it's a RAS wild-type tumor. So with 5 metastases, intrahepatic and retroperitoneal lymph node involvement, the situation is likely palliative. So what further tests would we now recommend for this patient? Would we do a PET scan, CT scan, EOS, chest CT scan, etc.? Well, no further test is required here. And I think, several of these answers might be correct. I do believe we need to have BRAF mutation tests. We should also get a chest CT scan because it's a rectal primary to serve as baseline for further treatment decisions. So we did do a chest CT scan, didn't show any further signs of metastasis. Treatment goal is palliative, and the treatment plan is systemic therapy. Now, what treatment regimen would be most appropriate? Should be use a bevacizumab-based strategy or cetuximab or panitumumab. I think this is really a very individual decision. We have data on various different on these various regimens. I personally prefer a combination chemotherapy with the addition of a biologic agent. So the question would be FOLFOX bevacizumab or FOLFIRI bevacizumab, or even FOLFOX and EGF receptor antibodies, or FOLFIRI and EGF receptor antibody. And all of this is potentially correct. In our hands here, the patient receives chemotherapy with FOLFOX bevacizumab for 8 cycles, had good response, and we get scans every 2 months. And after 8 cycles of therapy, we dropped oxaliplatin and continued the treatment with a maintenance approach of capecitabine plus bevacizumab along the lines of the CAIRO3 regimen. 10 months after start of therapy, that she then showed progression of lung and now new lung metastasis and other areas of disease. So what treatment step could be now used? She had minimal neuropathy, so we could potentially reuse oxaliplatin. We can switch to irinotecan-based regimen, continue VEGF inhibition beyond progression. We can also switch to an EGF receptor antibody-based therapy. And in this case here, the patient actually went to FOLFIRI plus bevacizumab. I tried to avoid going back to oxaliplatin too early because we can use it later. So I like to switch to FOLFIRI plus bevacizumab, but keeping VEGF inhibition beyond progression around. And 18 months now after initiation of therapy, the patient had, again, tumor progression. So another question, what can we do? We could potentially go back to oxaliplatin-based therapy. We can introduce an EGF receptor antibody here. I personally do not use VEGF inhibitors other than bevacizumab in this setting. Regorafenib could be an option, but the patient has not seen EGF receptor antibodies. So there are various treatment options that this patient has, and hopefully with the ability to use TAS-102 very soon, we'll extend this continuum of care even further. So in summary, I think we've seen that the integration of targeted agents with cytotoxic chemotherapy really improves overall outcomes. It's not this one sentinel event, this one breakthrough event that we've seen in colorectal cancer. We have seen that the various agents improve outcome, and the benefit that patients have seen over time is more the addition of incremental gains over time, and not just this one breakthrough event, perhaps with the exception of the anti-PD-1 antibodies in the setting of the mismatch repair deficient tumors. I think it's clear that RAS, NRAS, and KRAS mutations need to be excluded before we use EGF receptor antibodies. And of course, we always talk about predictive biomarkers. There's a continued search for predictive biomarkers that can guide our therapies, but the predictive biomarkers should not take anything away from us making the right treatment decisions for our patients based on their clinical presentation. So as a last point, I'd like to talk about the Colon Cancer Alliance, which is a leading national patient advocacy organization dedicated to increasing screening rates and survivorship. So the pillars of this Colon Cancer Alliance, which I think is a very important resource for patients and relatives of patients, is prevention, supporting research, and providing support for patients. And the contact information for the Colon Cancer Alliance is on this slide here for you to contact them for review. Another source of patient support is Cancer Care, founded in 1944. It's a leading national organization providing free professional support for patients and for people managing cancer patients. It's provided by oncology social workers and a network of world-leading experts and helps hundreds of thousands of patients every year. So this concludes our program of advances in targeted therapy, the role of VEGF and EGF receptor inhibitors in metastatic colorectal cancer. Thank you for listening.